of disease is skewed towards certain groups. It's going to even be more skewed because of inequitable access to vaccines. And I hope this is not true, but we could get to a situation where COVID is endemic in some countries, and even within those countries, it is skewed to certain populations that are also, again, suffering and dying more. That is on the side of health. But COVID is also actually pulling us away from other major health issues. So the inequities are spilling over to other health conditions, and we have to keep an eye on that. The other issue is that it's hitting socioeconomically the most vulnerable. They have lost jobs, they don't have money, they don't have food. They can't even have a meal a day that is decent for many people. So COVID is worsening the inequities. People have dropped out of school. What percentage of our candidate students actually sat their exams, even when we opened up? What percentage of our girls are now married, pregnant? And whose girls are they? It's the most vulnerable families whose children are dropping out. And these issues we are talking about are the most critical determinants of health. It's education, it's access to basics like food, like safe water. So these are going to get worse, and we need to keep an eye on that. There are certain things, for example, that we take for granted, like technology. Many years ago, it was a luxury to have a phone, to have access to internet, but now we know access to internet means good education and continuity of education. We are going telemedicine. So the most vulnerable getting left behind. But looking at COVID as a great opportunity for us, if we needed anything to really push these inequities into our faces, it's COVID. So we struggle, we can't even get a vaccine. That's when we feel, oh, it's so unfair. It's always been so unfair. And we can't wait for someone to solve these problems for us all the time. I know our keynote speaker has talked about the investments in health. We have to invest in health. We have to invest in health. We can't have the current investment and think that we are going to deal with the inequities. We can't have the current investments in the relevant sectors that are the key drivers of health, and we think we'll be okay. Education, we have a lot of data to show. If we don't have equitable access to education, we just can't do well in health. Food security, the environment, that is the next time bomb, and we are all talking about it. What are we doing with this? So what do I say in terms of COVID as a great opportunity? It is only a great opportunity in as much as we are organized to plan for a long-term strategy that starts now, or that should have started yesterday, in terms of how to harness this opportunity. This plan, recovery plan towards resilience, should not just focus on health. Of course, health is important. We need resilient health systems where we can be able to bring together everybody and leave no one behind. And I'll mention a few things with health. Honorable Minister, we can't bridge the gap without knowing who we are leaving behind. I know we have a lot of data on who is being left behind in many diseases, but we are also leaving so many people behind without knowing, because we have not invested in the tools for measurement, even just to know who is being left behind, where, why. That is for health. We have to do something about this. Know who we are leaving behind, but not just know who we are leaving behind. We have to reorient our policies and our programs so that we can bridge that gap. Then we have to implement, then we have to track. Are we getting better? Are we reducing the inequities? We can't build a fairer and healthier world without having those basics in place. So we have to do that. And to what extent have we invested in that, even as we move towards universal health coverage? Who are we leaving behind in terms of access to commodities, access to basics like information on health? Who are we leaving behind? We have to look at that. And I also have to emphasize that if we do that for health alone, we are headed nowhere. Because the public health we have to do has to focus on the critical health determinants. We have to focus on the environment. Food, safe water, clean water. We have to invest in education, and that education that leaves no one behind, including the girls that are the ones that bring up families and keep them safe and healthy. So we have to invest in these things. And Honorable Minister, one of the things I would really, really like to appeal to you to follow through, it's a whole of government recovery plan from COVID that goes long term, that brings together all the critical sectors that drive health so that we can do better. Only then can we build back better. We need to have had this plan yesterday. The reason why that is critical is some of the interventions we are doing are actually making the inequities worse. So if we had that plan yesterday, then we can rethink how we get out of COVID and how we do it better for everyone. That plan needs to be developed for health, long-term, building back resilient systems. It has to be built for the relevant sectors. That plan should also include not only a whole of government, but a whole of community approach. Because we can't get out of this by just looking at government alone also. With each of us in the community being a whistleblower, or is it a referee with no players? We need a whole of community approach. The whole of community approach should also start now, because recovering from COVID requires that we end COVID the soonest. The plans we have in place, now we have vaccines. People are just not vaccinating. They're just busy tweeting all sorts of information. So if you are here today, you are eligible. Have you vaccinated? Have you gone to vaccinate? I don't know, maybe some of you are not 50 and above. How many people have vaccinated who are 50 and above in this room? The hands are very few. The rest are below 50. The rest are below 50. If you're 50 and above today, if you have a comorbidity, get out and vaccinate. So don't talk about ending COVID today when you're busy sending out messages discouraging people from vaccinating. They are also health workers. Okay. Yes, please, let's end COVID. And some people have been saying, I think we need God in this. And it's good we have some senior men of God here. We need God in this is what they've been saying. A few weeks ago, I was talking to a colleague. She has refused to vaccinate, and she's saying we need God in this. And I said, are you sure God has not answered by giving us a vaccine in the fastest time possible? We always said we can't get a vaccine under 1 year. You heard those stories, did you? Why do you think we got a vaccine in a few months? Maybe that's the answer God has given us. So you've refused to go and vaccinate, and you're on your knees waiting for God to intervene, when God might have already intervened by using scientists to give us the vaccine. So what are we actually doing? Let's be part of ending COVID now and then accelerate the process to recovery. And this is the reason I say this is going to be a whole of community approach. Each of us has a role as individuals, as communities, as leaders where we are, not only to end COVID now, but to be part of the journey to reduce inequities and build a fairer and healthier world. Just like COVID, government alone is not going to give us a healthier and fairer world. We have to be responsible, because every time you are irresponsible, whether it's in the way you eat and what you do, you get sick, you're clogging the health system because you have got a disease you might have avoided, you are part of the problem. We have to get to that point when we can do that. Let me also say, because we have partners here that are regional and global, but it also goes to the government, that some of the things we are dealing with, we can't deal with them alone. Government alone might not deal with the vaccine issue. Government alone might not deal with the therapeutic issue. Government needs certainly to invest in scientists to do better and in the production. But sometimes it takes working with other countries so that together, perhaps in Africa, we can begin to chip away on some of the challenges and the inequities that we have, whether it's for vaccines, drugs, or diagnostics. We need to do better together. We need to do better together across the sectors within the countries, across the countries, with the countries working together in the regional frameworks, but also at the global level. And again, at our institutional level, we need to be thinking in terms of reorienting what we do. And let me just end by commenting on education. Education is going to be critical. How are we training our people? How are we rethinking education during and post-COVID? We can't go back to business as usual. One of the things I've been challenging my colleagues to think through in the School of Public Health is, can we continue to train business as usual? What have we learned from this pandemic that we need to infuse in our training? Are we training the best people to manage challenges such as COVID? What do we rethink? For example, when we teach health communication, we just never taught our people to deal with the craze of social media and misinformation. There are so many things. We just never trained well enough, perhaps, on how to engage with the community. How do you get a community to trust you? So even when you bring a good product, they can't use it because they don't trust you. They are listening to somebody else. So there are so many things we have to rethink in terms of the way we teach, in terms of the way we prepare people, and I think every sector needs to rethink similarly. So let me just end by saying we needed a plan yesterday for resilience, for recovery, so that we can really begin quickly and build back bigger, bolder, like many of us have said, but we need to act, and act. Thank you.
Thank you very much. Thank you very much, Professor Rhoda Wanyenze, for that analysis. Definitely, you've demonstrated that whereas COVID found that big, level of health inequity, it has definitely worsened it. We know that access and health equity, before even COVID, tended to follow the same gradient as socioeconomic status, but COVID did not mind that. It came for everybody. So it's very true that today the inequity is even worse. Now, Dr. Laro, Director, Clinical Services, as we struggle with COVID, I know that you as the director, you kept an eye on other services. Because I know as Uganda, we have some good progress, some good success stories on COVID. But what about the other services? What is happening? Isn't the inequity in terms of access to the other services, like emergency services, antenatal care, all the other services that the community still demands? Isn't this now even a bigger problem? What have we done for this country? Dr. Laro. How can we moderate the two?
Thank you, Dr. Okware. First of all, I want to thank Professor Rhoda for taking us through and highlighting the equity issues. COVID, you remember very well that at the onset of COVID, the country was already battling with other pandemics, other epidemics. There was yellow fever, there was definitely measles, and then we also in the process of preparedness because the EVD in the neighboring country. So probably allow me first to highlight that what are really the success story, because the management of COVID, the successes which we have, definitely had impact on the continuity of all the other essential services. And I want to highlight that this definitely can be a very long book which you can be able to write. For those who are students of public health, definitely this was the time when we saw really the political commitment at this play, because from the highest office in the country, the president and everybody, we were involved in this. We had the whole of government, partners, and community involvement. And I think if we address health in this context where everybody is involved, I think we will be able to make a headway. The other key aspect of it definitely is the science, that everything which was done was based on critical analysis, and it was informed with science, and I think even when the president spoke, the scientists have said this, and this is what we should do. We should be able to do. The other aspect is transparency. I think Uganda as a country, we did put all our figures on the table. We're reporting on the cases, even when we received the first case, even when we lost the first case in Misindwa, and the subsequent numbers, the numbers you could really be able to follow the trail. So this broader aspect of transparency, but key definitely is collaboration with all the other partners, CDC, WHO, African CDC. The private sector was key, and then maximum use of the local staff. But allow me, definitely, that as you have indicated, that we kept a tab on the continuity of services. When we had the Ebola outbreak in West Africa, many people died, not from the Ebola, but they died from other conditions. We've been leading in this area, working with different partners. And if you saw that, even in all communication which will come in from allowing pregnant mothers accessing care, the patients to travel to centers, was based on guidance which was given by the continuity of essential services. And we've been able to follow up the different indicators, over 20 indicators in maternal and health services. And we saw that definitely we had a dip from March to about May, but I think from July to August, we picked up. So we had to look at in this aspect that the most important aspect of it was protecting health workers. Because if the health workers got infection, then you run a risk that you will not be able to deliver the essential the essential services. So one of the key parameters which we really worked was the issues of provision of PPEs for health workers, and being able that they are able to be protected so that the infections. The other aspect is definitely seeing that we worked with partners to mitigate some of the cases. The districts were sharing experience, and then we're looking at that we needed to expand investment in these areas. So as government, it has also been an opportunity for the strengthening of health systems, because now we've been able to see that this is the chance for us to operationalize the regional ambulance system. We've been able to see that we've been able to procure ambulances. And I think now, including even the motorized boat ambulances, because this was all trying to address the issues of inequities, so that even both those in the land, in the waters, are able to access emergency services. We guided and proceeded to distribute nets as one of those aspects, and we were able to distribute about 27,000 nets, because malaria remains the biggest killer. We had approaches on people to be able to access their refills for HIV, and TB has been on our agenda, because we're saying that if we don't address this, you will actually find that more people will actually die not because of COVID, and actually more people have died not because of COVID, because of other conditions. But we didn't want to attribute that because they were not able to access. So this has provided additional services, and the other area definitely is upgrading the health center phrase, because this is another approach for maternal and child health services. I think I could be able to stop there.
Thank you. Thank you very much. A round of applause for Dr. Olaro for that analysis, keeping tab on the continuity of services, which is very, very important. Now, finally, we listen to Professor Maswa. I know that you can speak even without any guiding question, given your experience in this area. When we talk about the world being fair, maybe healthier, yes, but being fair, I know that you have that exposure, you have attended all these global meetings, and you watch how events roll, how decisions are made. Is this world fair to every continent, to every every region. We would like to hear a genuine, answer from you before we begin to assume that the world is fair to all of us moving forward. And given that you are now an elder, you're still very active, participating in the sector, but you can stand from aside as an elder and watch what the sector is doing. Do you think that we have catered for equity in this process? In the beginning of the pandemic, we all thought, and many people thought, that maybe the opportunity that comes with COVID is that now we will be priority as a sector. We will have the resources to equip our facilities. We'll have the opportunity to put right the system so that after COVID, we have a better health system in Uganda. What's your opinion of the events so far? Beginning with the issue of fairness, Professor.
Good morning, all. Honorable Minister, UN Representative, Dr. Jonas, WHO Country Representative, our pastor, my colleague panelists, ladies and gentlemen. Is the world fair? Will the world ever be fair? As a schoolboy, that issue arose. One student asked, they were complaining about something. And then the teacher said, the world is not fair. The world will never be fair. It is up to you to make sure that what you need, you fight for it and get it yourself. That was what that happened. That is now how many years? Is that 60 years ago or something like that? But also the foundations, the biological and social foundations for fairness are there. You know, as human beings, species Homo sapiens, we have empathy inside us. If, for example, you are sitting in your office or somewhere, your house, you hear a noise outside, you look through the window, someone has been hit by a car or a boda, it's lying down or bleeding. Inside you, you don't clap and celebrate. But instinctively, you feel sorry for that person whom you don't know. And those pictures which are shown of starvation here and there, they cause a global reaction to contribute to save those people from perishing. So as human beings, we have that empathy. And it is that feeling for each other that has made us to work together as humans to transform the world to our advantage. So at the end of the day, the world can be fair. The raw materials for social justice, social cohesion are there based on our feeling for each other so that no one is left to suffer alone. Indeed, the other tendencies also are there, the opposite ones. Greed, selfishness, jealousy, they are also there. And they are in permanent competition with the empathic tendencies. But by and large, in society, it is the empathic tendencies which prevail. And that is the reason why we are where we are now, even here gathered to see how Uganda can emerge better from this pandemic. Of course, also, this is a good day to do this. I want to congratulate WHO on this day and the UN I am wearing the WHO tie. I don't know if they are in the market somewhere, or my brother Jonas get these ties for these people to buy. And it is really an opportunity, and I congratulate Honorable Dr. Cheng for bringing us together, for leading this. It is a tremendous opportunity for us. I'm now going on to our next, to the next question that you asked. What can we do here in Uganda? And from the historical point of view, we need community systems that leave no one behind. We need community systems which are owned and driven by the people themselves. And most of the diseases which we have are preventable where people live. Health is made at home and only repaired in health facilities when it breaks down. So we have to focus on community health systems as the foundation for integrated people-centered primary health care, which is also the foundation for achievement of universal health coverage that leaves no one behind. And investing in primary health care and integrated people-centered PHC is really where we should be. In returns on investment in that area are comparable, certainly not less than investing in Karuma Dam or this road or the other one. And I will show you in a moment why. And historically here, we've focused on primary health care. It has changed a bit. When I was waiting for this meeting with Professor Wanyenze here, I was asking her how much time public health has in the curriculum of the students. And I was telling her that the curriculum that my generation went through at this same Makerere Medical School, it was called preventive medicine. It had the lion's share of the curriculum because those people at that time believed that getting out graduates who understand prevention of diseases was the most important thing to do. And very often you would finish your internship and you go and become a district medical officer without training in any public health at all. So we have those traditions. And then the NRM government, when they came to power, they set up that award commission. And the biggest recommendation of the award commission was for the health system to focus on disease prevention and health promotion. And it was out of that recommendation that during the development of the first national health policy and the strategic plan, we created that Health Center 1, which is a virtual center, a community-based center, which job was to promote the role of communities and in preventing diseases. Health Center 1, 2, 3, 4, up to 5. So we were very clear that this is needed, and the system in Uganda is set up for this. And it has helped us quite a lot. You know, Ebola came, and we used Ebola to build structures which have made Uganda really very successful in even COVID now. So, out of COVID, the opportunity of COVID, we must really use it. We must use the opportunity of COVID to transform the health system in Uganda so that beyond COVID, and with new outbreaks coming, because there are going to be more outbreaks, we are ready, particularly with the foundation which is led by people themselves. And fortunately, perhaps the hat I am wearing, I don't know how you nominated me to speak here, but my active hat now is one of being the chair of the Community Engagement Strategy for COVID. And this is a tremendous opportunity which we should build on. We have launched a strategy, and all districts have been written to by the Prime Minister to establish village COVID task forces. And the government of Uganda has put some money to 4 districts now. The money just arrived this week. It took a long time, Honorable Minister, for the money to reach, but it has reached the 4 districts to be able to support a VHT in that village to do their job, which we will say something about in a moment. So I would like us also to link this. As it happens, there was already before COVID a plan to develop what is called a national community health strategy for Uganda. I understand a consultant has been hired and all this is supposed to happen, and let's coordinate. The committee which I chair now was brought together with another committee which the Ministry of Health was in the process of setting up for this other purpose. So we have one committee which is moving forward together to establish that national community health strategy. And I would like us to immediately do everything possible to make sure that this strategy is completed, that the village COVID task forces are set up, are active throughout the country. And by the way, Honorable Minister, this is happening because here in Kampala, for example, with the support from Red Cross, more than 1,000 village health committees, village COVID committees have been set up by Red Cross. And it may be one of the reasons why the epidemic is where it is now. I don't know. And this village COVID, these VHTs, we have their contacts. They have been told to take people for vaccination. They are talking to people about COVID and so on. So already I think we are starting to see some of this. And then I would like to also argue that if we take this route, we are going to achieve SDGs, not just UHC. Because when I sit together with village health committees in the districts and I hear them talk about how they are addressing the sources of water, how they are addressing gender-based violence, how they are addressing a conflict in the community, it feels so good. And if these committees are actually active and working, then we will be where we are. So we are short of time. We will be having a discussion. I would now like to just tell you that these are the 3 elements that we in Uganda could take forward. I've already talked about establishing these village COVID task committees. They become in future village health committees. They need to be led by the administrators, not just health workers alone. Ours, they are led by LC1s, and they have all of society there. They have the LC1, the Secretary for Women Affairs, the Secretary for Defense. They have also agricultural extension workers, community development people. If there is a school in the village, the school is represented, and so on. So also religious leaders and cultural leaders are members of those committees. So it is rather that whole of society approach that this is taking. Then number 2, let's define a minimum package of services to be delivered by those VHTs, by those village committees. And by the way, you have that already in the government of Uganda. There is a package or a standard, a service standards for Health Center 1. Let's revise them, let's do what. But then those are the services which should be provided from the tax base. Honorable Malango, you congratulated the government for passing the National Health Insurance Bill. But I don't know whether we should congratulate them, because they are not working as whole of government. One arm is doing this, another one is doing that, and but let's get this minimum package for the village funded by the tax base. Then insurance can come and do other things for the population. And then lastly, we provide skilled workers, motivated skilled workers. And these are VHTs who are facilitated and paid. And to move forward, in conclusion, particularly Honorable Minister, let's complete setting up these village COVID task forces together with this Ebola. Let's try and get into the budget for 2021-22. I spoke to the chair of the budget committee. They say this item under community, under Qs, is there as an unfunded priority. But they are saying if the minister comes and tells us that this is, they want money for this, we are likely to consider. So let's try, if possible. And then there are also development partners here. What I have found the last few months with this committee work is that there is a problem here. The three ones, implementing one policy and strategy in the district and using one implementation mechanism and one monitoring mechanism is not happening. When donors talk to us, they say we are in this district, that district, the other districts. When we go to the districts, the district authorities don't know about them. And I feel very stressed by this. Yet we have the Health Development Partners Group. They have been here for a very long time, and in my days they worked very well. We were having a sector-wide system which was working very well. Can we get development partners to work through the districts, the district health systems? And if we do that, I think we are going to have in Uganda one of the strongest community health systems where a VHT visits 5-10 homes every day, has a health register, and every home they record this is Omaswa's home. Omaswa has got hypertension, he's got diabetes, his wife is pregnant, she's going to deliver in that health facility. There's a TB case here, malaria has come up, the rains have come. What do we do through the village health committee? We will have the best and strongest health system in Africa, comparable to that in the developed countries. Can we do this? And I think it is feasible, and this is the opportunity with COVID. And I hope, Honorable Dr. Cheng, when Mr. Museveni reshuffles his cabinet, you stay so that you do this. Because now, if you bring someone new, we have to persuade them and so on, and they may not work with us and so on. But this is our chance. Let's do it. Thank you very much.
Thank you very much, Professor. You have summarized it all. Now, I had promised that I would give a few minutes for the audience, but we have already walked down 1 hour, over 1 hour actually. We allocated 1 hour for this session, and I know that the Honourable Minister has other commitments before 11. So I don't know whether anybody has a quick contribution, a quick question. before we conclude this. Yes, I'll give the Reverend and the lady behind. Only two. MC, microphone. The panelists, I request you to stay, and the Honorable Minister will join you. Don't leave. You give company to the Honorable Minister after the two questions.
Thank you so much, the Honorable Minister of Health and UN Resident Coordinator, World Health Organization representative, the panelists. Again, my name is Bishop Julius Peter Yet. I am a Deputy Head of Born Again and Board Member of Interreligious Council of Uganda. Moderator, I have three thoughts. As a senior religious leaders, and recently I just concluded moving throughout the country, listening to the people that are not necessarily living in cities and towns. My thoughts, however, begin on the positive, that on November 18th or 26, 2020, I was taken here with COVID-19. And the experience I had slightly different, but I know why it is different. I want to congratulate and appreciate the government of the Republic of Uganda and the Minister of Health. For the first time, I had to look into the facility of Mulago Hospital, level 6, and I received a high-class treatment. I was communicating to my friends in US and China and all that, and was showing them how advanced we are as if I was not sick. I recovered very fast. After that, I continued my religious duties and development. Out of that, I wrote a big book, Time to Hope Again, which I have brought a copy for the Right Honorable Minister and a few others in appreciation to the life and the service they're giving to our country. Honorable Minister, thank you again. My three thoughts therefore are, one, have we done enough sensitization benefits of the vaccination to the community? In my tour, I went with a medical personnel from the United States of America who is still with me. We were the only two people putting on the masks when we went throughout the country in the village, countrysides. My elder brother is the chairman LC1 of the village in Agago. And I asked him, Anthony, have you ever had a mask? He said, I've not even touched a mask. I see it because he doesn't have TV. When I go, I have not even touched a mask in my hand. He said, has anybody suffered from COVID here? He said, we hear about COVID from TV. We've just concluded top interreligious national Uganda retreat, and we discussed about the masks, about the vaccine. It went into a primary, secondary school debate whether we, the top religious leaders, should take the vaccine or not. And we said, let's meet on the 6th of April, and unfortunately Archbishop passed on, and we convene again whether we should take the vaccine. So, have we done enough sensitization? Thought number two. Could COVID be somebody's business? And that person or those organizations are using World Health Organization, UN, governments of the world, to be their marketeers. I returned from United Arab Emirates last week. Their approach and what they're doing there is completely different. It was a real torture for me to travel there, but I had to travel. Could we think about that? Because it's a big debate with the people. You know, we share the people, that the citizens of the world. The government claims they belong to them, but before they go to government, then our churches and our mosques take more time to raise them in morals. Finally, third and final thought. What are we doing with the diseases that are killing more people than COVID? Malaria, maternal health, 16, 18 people in that respect. And other issues that probably to us as religious people, as citizens of the nations, should draw more attention and urgency of the health system and governments. In my book, I come with my quote that says, Africa is suffering from transgenerational transmitted poverty, and the only vaccine is transgenerational thinking. Could we think, as Professor Mashwa says and Professor Naroda, could we think transgenerational to plan for the health of Africa, Uganda, 30, 50 years from now? Thank you. Blessings.
Thank you very much. So we get the last question, but you have to be quick. We give you a few seconds. And as you prepare to do that, can I invite the Honorable Minister to join the panelists up here? And I also request Dr. Jonas to get ready to make your closing remarks. As I said earlier, this is a breakfast meeting. It's live on TV, and we don't want to close before they project the WR and the Honorable Minister on TV. So we are sorry that we are running fast, but our time is getting finished. So you've got the microphone? Oh, microphone. The lady behind. Okay, the Honorable Minister will join the panelists as the WR prepares to come and make a statement. I'm told today is also the birthday of WHO. I read somewhere. So this is WHO Day, Honorable Minister.
I got the microphone now.
Just wait a bit.
Okay.
The minister to sit. Okay, go ahead.
Okay. Good morning, everyone. My name is Angel Ntege. Seeing people looking for me. My name is Angel Ntege. I am a community person, and I'm so grateful to be part of this big day. First of all, I would love to thank the panelists for the submissions, for the information they have given to us. My concern is on the vaccination and information that we have in the community, and the myths and the misconceptions we hear. I've heard Professor mentioning that the social media is doing us bad. Yes, I accept, and I would say they are not, because at the beginning of the pandemic, we saw a lot of sensitization about COVID-19 on radios, on televisions. Ministry was not settled until every person got to know about COVID-19 pandemic. And when it came to the vaccine, we are not getting the same. In a certain meeting, I requested and give my recommendation to Minister of Health. Can we go back to the drawing board? where we all got the information about the pandemic. Every time we got those the talk shows, people got to know about it. When you go to the community, like for me who works in communities, yesterday I was in a dialogue, and people were telling us so many different information. And when we talk to them, they'd be like, at least we have gotten something live. But what we have been reading on social media is just diverting us. So these meetings, the dialogues that we are holding indoors are good to us who are already informed. But the person who do not have this information will not get it, because the way they perceive it from one communicator to the other one, it reaches the person differently. So I request that as we are doing the sensitization about the COVID-19 vaccine, we should go back and do what we did in the beginning. I personally, taking that vaccine, had to consult from 4 doctors. I personally, who is a bit informed. What about the DNA thing? What about the PLHIV who do not know about everything? What about this, the blood clotting? Until I got from a doctor, direct call. So how many got the information I got from those doctors that I called to go for the vaccine? So I request and give my way forward that we go back, do the sensitization like the way we used to do it. We shall forget about the social media myths and misconceptions. Thank you.
Thank you very much. Those questions will be answered by the WR, and definitely the answers are also in the remarks of the Honorable Minister. So at this moment, I request you to join me in appreciating the panelists who have done a wonderful job this morning. We thank you so much, and we couldn't have got better people to guide us in this discussion. So in the interest of time, let me take the honor now to invite the WR to make a closing remarks or statement, and also request him thereafter to invite the Honorable Minister to speak to us. WR. You're welcome.
Good morning. Honorable Minister of Health, the UN Resident Coordinator, distinguished panelists, partners, Ministry of Health officials, ladies and gentlemen, all protocols observed. I prepared a long speech, but considering that we are very strained with time, I'll try to highlight very few issues. One is, I was asked, what is it all about World Health Day? WHO is one of the UN agencies, specialized UN agencies, and if we look how it is formed, during the formation of the United Nations, there wasn't a specialized agency thought for health. But in the fringes of the San Francisco conference, a few doctors came together and persuaded the Secretariat that there is a need for a health organization which would be bringing all the health partners, and that member states should consider health. And these people persuaded health to be a major feature in the UN Charter. If you look into the UN Charter, the word health is one of the most frequently mentioned words. They also made sure that health is recognized as a human right. But because already the charter was negotiated, they requested member states to meet a year from the 1947, which is in 48, to meet in New York and discuss about forming a global health organization. And in then, at that special international conference, the WHO Constitution was drafted. And as you know, international law, a certain number of member states have to sign any agreement before it becomes a global agreement. And it is on April 7 that sufficient member states, over 2/3 of the member states, signed, and the last signature was on April 7, which makes it a legally binding agreement. And it is from that day that the World Health Day was designated. And yes, the World Health Day is the birthday of the World Health Organization. And every year we celebrate it for that. So that's my first comment. The other is, this year is also a different type of World Health Day. Not only that we started celebrating it on April 7, but we are going to continue reminding member states and everybody. The theme would continue to be our focus until the 12th of December 2021, when we will commemorate universal health coverage. Because health equity is the cornerstone for universal health coverage. One of the things which is unique in that World Health Organization's constitution is, even in the earlier days, the realization of our interdependence, that health is a human right, and that we have to look into all social determinants which are contributing to health. And those social determinants are very much related to health equity, because how a person survives birth, grows up, manages to go through diseases and recover, the life expectancy is not only dependent on how good a health service we have, but in all other aspects. On how society looks racial discrimination. It is dependent how we educate our children. It depends where one is given birth. It depends where one works, whether the environment is safe, whether air is polluted. In general, our health and survival depends on how we are in the overall of society. So this year we will emphasize more and more that to make sure that we have a healthier population, we also have to tackle gender inequality, economical inequality, educational inequality, and all other aspects of inequality. And more than any other time, 2020 has taught us something which we have forgotten, or we have decided not to put in the front of our thoughts, and that is our interdependence. And our collective survival is dependent on our reliability on each other, our solidarity, our fairness. Let's take the example of the vaccine. Unless we make sure that the world as a whole has the necessary herd immunity, variants will appear. And some of the variants of COVID will be more vicious than the previous one, making all the billions of dollars of investment on vaccine a threat. So that is why last year, and we will continue this year, we are emphasizing on equity, that everyone has to benefit from the technologies, the medicines, the vaccines, the public health efforts, so that all of us could survive. Because if we are not also taking care of the less privileged in our community, this disease will look into that weakness of society to attack us again. If we would have looked into fair distribution of diagnostics, of treatment, of public health measures, from mask to hand hygiene, from educating the public, we would have been in a better position to prevent this disease from becoming a pandemic, and from it developing variants so that we see another wave coming up. And now we have one more tool, the vaccine. Unless we make sure that the vaccine reaches everyone, not only the developed world, but also everyone in every community, and even the least privileged ones, this virus will attack us again and make all the tools we have put ahead useless, back to zero. So that's why we have to persuade our brothers and sisters to take the vaccine, and not to forget the public health measures of wearing masks, keeping distances, hand hygiene, and to be in an outward environment to ensure there is better ventilation. And in every is becoming more dependent on our neighbor's help. So that is why we have to look into equity as a major health investment that we have to do. Government, civil societies, the public. And one of the tools we have, as Professor Maswa has said, is to get everybody involved in health through our community engagement, so that everyone is aware of health and is a cadre for health. And in governments and in sectors, health should not only be an issue of the Ministry of Health, but every sector. Health in all policies of development, it has become an issue of survival. And to survive as a human species, we have to address health inequalities, which is dependent on also other inequalities in the social, economical, and even political realms. And at this point, it is a great privilege to invite the Honorable Minister to give us her guidance on this issue. I have a long speech which I will circulate if you want to have it. Thank you.
Thank you very much, Dr. Jonas. Our panelists who are still sitting up here, the UN resident representative, the WHO country rep, our partners in your various capacities, civil society, private sector, and my teams, the directors and commissioners from the Ministry of Health. Good morning to you all. Allow me first of all to start by thanking our panelists for a very good discussion this morning. Professor Roda, thank you very much for taking us through what COVID has exposed, the inequities among our societies, and Dr. Laro for telling us what Ministry of Health has been trying to do. And lastly, my teacher and mentor for reminding us that we can do better and there is room for doing better. Only if we are committed, if we are determined, if we are focused, and if we are holding our hands as one. I would like to leave you with one question, which I thought would come out very well. Does corruption breed inequity? Do wrong social media messages breed inequity? Do we ourselves have the potential for breeding inequity? Because many of us in this room are responsible for some of the inequities that exist in society. WHO, happy birthday and congratulations. On the 7th of April every year, Uganda joins the rest of the world to commemorate World Health Day. Globally on this day and throughout the year, health workers, partners, leaders, and communities are mobilized around a particular theme or health topic to give it attention and spur activities and interventions aimed at improving public health. This year, the theme for the World Health Day is health equity, with the slogan, building a fairer, healthier world. The purpose of this theme is to position health equity high on the global and national agendas, to solicit political will, galvanize support from governments and donors to realize health equity. It is also meant to influence country priorities by highlighting key barriers in equitable access to health services, promote actions to work around those barriers, and provide recommendations and tools to support multi-sectoral actions to achieve equitable health outcomes. But as you clearly heard from Professor Roda and Professor Maswa, I don't know whether the theme and the world commemorating this will address equity issues. Already many countries are hoarding vaccines while others don't have. What does that mean? You buy so much, you keep. And Africa has no vaccines. And Africa is living one day at a time. And it is the richer countries buying all the vaccines, while the poorer countries, like small birds looking up to their mother who has a worm. I will leave you to picture that. Therefore, through the year, the Ministry of Health will raise awareness and formulate measures and policies that address health inequities. We will highlight the advantages of improving health for all through better and more equitable health services and maintaining the conditions for health. The Ministry will continue to engage all sectors to address health equity through knowledge exchange activities and products. In addition, we will strengthen partnerships to accelerate progress towards health equity. Lack of healthcare equity is to a situation of high infectious and non-communicable disease burdens. For example, in Uganda, just like any other African countries, there are substantial healthcare disparities, with most healthcare resources located within urban centers, even in predominantly rural countries. And yet again you ask yourself, and I'll give an example. Vaccines were distributed throughout the country, and we have been encouraging people to get vaccinated, but they are shunning vaccines, and they are still waiting to see who will die. And they keep on asking each other, is he still alive? Has he got a swollen neck? Has he got bleeding tendencies? But the coronavirus is not waiting. And for those of you who are in the room here, allow me to inform you that the numbers are growing every day. And as most of you are already aware, usually the resurgence is worse than the first wave. Professor Roda, Professor Maswa, those who have shunned vaccination, are they part of the teams who are causing inequity? I'll keep on asking you those questions, and then you can address them after. This situation requires a robust primary health care network to diagnose, treat, and monitor patients due to a long continuum of care. The government of Uganda continues to prioritize access to health care, whereby 86% of the population is now within a 5-kilometer reach of either a public or a private health facility. Of course, issues concerning human resources, equipment, and others are also important, and you may ask, being within 5 kilometers, am I really getting quality care that I deserve? This is intended to bridge the gap of distance and access to health care, as well as the economic opportunity costs associated with travel to the health facility. Furthermore, Uganda has reported a high level of out-of-pocket health expenditures, averagely 40%, which is 25 percentage points higher than recommended by WHO regarding levels of out-of-pocket expenditure. High out-of-pocket expenditure has led to a high incidence of catastrophic health spending among the poor in Uganda. To address the health inequities in Uganda, several measures have been put in place. For instance, recognizing the increasing amount of catastrophic spending, the Ministry of Health put forth plans for a national health insurance scheme that will be financed through taxes paid by individuals in both the formal and informal sector. You will allow me to talk a little bit about that, because many of you are wondering, if she's talking about the national health insurance, why did Ministry of Health make an attempt to withdraw the national health insurance from the floor of Parliament? Yet, the Ministry of Health stands to benefit the most from the National Health Insurance Scheme. And I will highlight for you the reasons. The bill in its current form is not very popular among the investors among the workers, among the business people, and among the private sector people. Why? Because people are saying they earn little, and yet they are the same people being requested to pay again to meet the needs of the poor. For example, the health workers, you are still complaining about salary. And here we are saying, let's deduct another 4%. So they were not happy. And people said, if you don't change the bill in its current form, we will not join your national health insurance scheme. So we needed to have dialogue, and we had dialogue. And during dialogue, 4 points came up. The first was that we all love the national health insurance. That made me extremely happy. And everybody said it is important to have it if we are to have better health services in this country. The second was that it must be mandatory, not optional, mandatory for basic services. And that was another good point that is missing in the current bill. And the third was that everybody must pay for purposes of ownership. Human beings don't appreciate things when they are not contributing. When they are contributing, they own it. They make it a point to check on whether it is working. Even when you talk about community ownership, Professor Maswa, communities will participate when they see the value of something. And so during dialogue, everybody said, let everybody pay. Because the investors are saying it will increase the costs of doing business if you say we cover for our employees. And that will cause taxation to go higher. The workers are saying, you have squeezed us too much to a corner. So stratify the paying methods and give a certain amount of money to those in formal employment. Again, come down to those in the business community, come down to those in the villages, to the last person. Even if they contribute 5,000 per year, it is important. Let everybody pay. And we agreed. And then the fourth thing was that we should not attempt to start creating new mechanisms of collecting money. We already have bodies in place that collect money. Can we find a way to use these bodies to reduce on costs of setting up the national health insurance? Beautiful point, which was missing in the current bill. So if you ask me whether it will be signed into law, I leave you to answer that question. Because this complaint was put on the desk of one who was supposed to sign it into law, and he clearly said, wait a minute, before you proceed, consult. And we have consulted widely, and the insurance regulatory bodies, the Ministry of Health and others are doing actual studies to determine how much people should pay, including those in the communities. And I personally think that is the way to go, so that even our health center 3s in the villages are held accountable. People will say, I am paying, so I want value for my money. Not for people to sit back and say, government etuyambe. Everything is on government. But who is government? That's a question for you to answer. So the Ministry of Health has revised the resource allocation formula, that is for funding, to enhance equity in distribution of local government transfers across districts and health facilities. Likewise, the government continues to provide subsidies to private not-for-profit health providers to lower the user fee, while health care is provided for free in the public health facilities since the abolition of user fees in 2001. Now, I have paused here because that statement is not correct. That is the statement we always make. But me and you know that we pay for health services. Wherever you go, you pay. To address the challenges of access to health facilities, the ministry has upgraded over 200 health center 2s to health center 3s in a bid to ensure that every sub-county has a health facility at the level of a health center 3. This level of care provides all forms of health care during and including maternity services. Now, many of you have been asking questions, but why is the ministry trying to get rid of health center 2s? Health center 2s are good, very good. They are closer to the communities, provide quick access to services. We are not getting rid of them, we are upgrading them, because the health center 2s act as outpatients. If you listen to Professor Maswa, we had the virtual health services, Health Center 1, down in the communities. Now the health center 2s were in the villages. You could go and get outpatient services, a blood test for malaria, some nice health talks, and you are gone. But we are saying, if we are taking services closer to the people, let it be a one-stop. If I need admission for a simple illness, I should get admitted. So even in sub-counties that are very big, we are dividing them up to put a health center 3, so that everybody is within a 4-kilometer reach to a health center 3, where you can get laboratory services, you can get admitted, your child can get treated, you yourself can get treated. So it is a modification to take services closer to the people. But the other idea was to have it there as a place for supervising our community health workers, so that the health workers in a health center 3 can freely interact with the community health workers and close the gap that exists. So as we commemorate the World Health Day today and throughout the year, the government of Uganda will monitor and address health inequalities that exist in our communities, which affect the ways Ugandans live, their health outcomes, and their risks for premature death. This is one of the long-term strategies towards attaining universal health coverage and hence achievement of the Sustainable Development Goals. Now, before I conclude, I wish to speak a little bit about information sharing that one of my daughters there spoke very passionately about. It is true that during the season of elections, we slackened a bit in sharing information. But ever since we received vaccines in the country, we share information every week. Every week. But what I have observed, and that is why I asked them to respond whether social media, wrong information, does not cause inequity. People prefer the sensational stories on social media, not our correct stories. And I would assume that even my daughter there, when she sees a sensational story, she's attracted towards it much more than Jenna Cheng's statement, which looks long and very boring. and yet my statement is packed with information. And this statement is shared with all the media stations. But what do? They will pick something small where I have said we are not sure whether we are going to get vaccines on time. That will be blown out of proportion. And all the others I have said will be ignored. One of them, I spoke about alcohol, because people were saying if you're vaccinated, don't take alcohol for 45 days. And so all those who take alcohol were saying bye-bye to the vaccine, because they prefer to choose to choose alcohol over life. Isn't it sad that you choose alcohol over life? And so I spoke about that. And I said, WHO advises that excess drinking of alcohol is harmful to your health. And we still maintain the same. But taking it in moderation is not bad, if you must. But go ahead and get vaccinated. And people ignored all what I said and preferred to continue posting. If you get vaccinated, no alcohol for 45 days. And that is being promoted throughout. Not only by the public, even by my own health workers. They are also part of the inequities. That clearly showed me that even my own health workers, my own team members, don't read the information that we share. So if in-house people are not appreciating the information that we take time, Ministry of Health, WHO, CDC, to compile and share, because people prefer sensational messages. If I vaccinated a dog today, everybody would get excited. Everybody would come to see whether the dog is alive or dead. So we are part of the reasons why there is inequity in health. But we can also be part of the society to build a fairer and healthier world by what we do and what comes out of our mouth. So I want to charge you today to be committed for each and every individual in this country. Continue to remind yourself that you are doing what you are doing for the over 45 million people who are looking up to us. Even as we commemorate today, they are asking themselves, what is going to change? But that change begins with you. It also begins with me. And we can do it. We can fight COVID-19 together. We can ensure that the essential services are of quality and acceptable, and we can enhance public health for the betterment of this nation. Lastly, Professor Rhoda talked about a whole of government plan to ensure recovery post-COVID in all sectors. Professor Rhoda, I want to reassure you that that plan was already made by Cabinet and widely discussed and shared. It requires that each sector comes up with its own plan hinged on that broader plan. So again, I want to task all of us to start thinking every day what we want to see post-COVID, or even if COVID remains endemic, at least we hold our hands and walk through this journey called life together. God bless you.
The day the world stopped was the day we found where to go. From now on, we are not going to leave anything on our plates.